The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hi, everyone. Welcome to this episode of TMD Demystified. I'm Tony Urbanic, and I look forward to speaking with you today regarding a topic which is near and dear to my heart, which is the correction and the mitigation of temporomandibular joint disorders. Actually, it's just one disorder. The disorder is inflammation within the temporomandibular joint. I think that's a good starting point on any of the episodes, and that is the constant misunderstood that has everyone absolutely confused about temporomandibular joint problems. But that is not the topic for today. I think that's been covered several times in different episodes, but just keep that in mind. If you understand about inflammation and the effects of inflammation within the temporomandibular joint itself, causing all the symptoms of temporomandibular joint disorder, then it is really just one disorder. It is inflammation within the joint that causes all the symptoms. The symptoms are not the disorder. They are the description of the disorder, but not the disorder itself. They are symptoms. The disorder is inflammation within the joint. Made my point. But today, the topic is tinnitus, subjective hearing problems, and vertigo and TMD. Tinnitus, subjective hearing problems, vertigo, and TMD. Those three symptoms, as far as our current ENT and medical care is concerned, are very vexing and in most cases unfixable, according to most ENT doctors. But what we do know with certainty is that those three symptoms are accepted symptoms associated with the temporomandibular joint problem and temporomandibular joint complex. Tinnitus, which is the correct pronunciation of ringing in the ears, tinnitus. Subjective hearing problems, which I describe most often with patients because that's what they describe to me. They say it feels like I've got water in my ear. I can't clear my ear, like I've been swimming and can't clear my ear. That is the most common description from the patients, but they also have other descriptions that the ear feels full or like they've been in an airplane. And then the third is vertigo or dizziness. I think the difference between vertigo and dizziness is vertigo is a recurrent problem with patients. And I think everyone has experienced some episodes of dizziness, whether they be associated with social environment or activities, or that constant feeling of dizziness, which can occur in different situations, chronic illnesses, things like that. So those three symptoms, tinnitus, subjective hearing problems, that's the other patients frequently say, I just can't hear as well out of the ear or the ears, and then vertigo. Are chronic complaints of temporomandibular joint problems, and the relationship between inflammation and those three symptoms have not been discussed and not been dissected in the literature that I'm aware of. But I'm going to explain today how inflammation within the temporomandibular joint actually causes those symptoms. It's an anatomical situation. Now, as we discussed before, inflammation is an incomplete understanding of all the aspects of inflammation, but it's a compilation of cellular and infiltrative fluids, biochemical reactions, and biochemical material that makes up inflammation over a period of time, changing over a period of time, depending on which stage of inflammation we're in. But the point is, when the joint becomes damaged, it becomes inflamed, which is inflammation is nothing more than the body's response to damage in an attempt to mitigate or heal. And when it doesn't mitigate and heal, the inflammation continues on as chronic inflammation, which is what actually occurs with temporomandibular joint disease, chronic inflammation in the joint. When that inflammation goes on long enough, it is obvious that inflammation, and especially inflammatory fluids, can infiltrate throughout the area, the surrounding area of the temporomandibular joint. And being the anatomist, I was trained in anatomy and cell biology with independent degrees and studies, and actually had my master's degree in that area. I want to bring to your attention how that occurs. Now, you all recognize one of these. I think probably everybody went to dental school, got one of these to study the cranial nerves and the relationship of the maxillofacial region as you became a dentist. And so I want to try to show you, it's not an ideal way. I think the camera that I have here will do a reasonable job of showing the glenoid fossa of the temporomandibular joint. Let me do this for a moment. I'm sure you're all familiar with that aspect of a dried skull and the glenoid fossa and the condylar head, which fits in the glenoid fossa. But what I wanted to show you was the relationship within the glenoid fossa of a anatomical structure. Here's the glenoid fossa, and in the posterior aspect of the glenoid fossa is the petrotympanic fissure, petrotympanic fissure, or Glaserian fissure, which sits right in the posterior aspect of the glenoid fossa. That fissure gives a direct communication to the inner ear right on the inside of the tympanic membrane, right next to the chorda tympani, which is the nerve which elicits an initial hearing. And it's obvious that if you have chronic inflammation within this joint, where the inflammatory biochemical fluids, I'm not sure whether you'll get a cellular infiltration through that tympanic fissure, but that fissure gives direct access to the inside of the temporal bone, where the auditory mechanisms are, and are the mechanisms for keeping us upright. And when that inflammatory fluid gets within the middle of the inner ear, the temporal bone, it can generate responses just like any inflammatory fluids can do in any place. And it will generate those three symptoms: tinnitus, subjective hearing problems, and vertigo. And what we found, quite simply, is when you unload the joint long enough to allow the inflammation to decrease or diminish within the temporomandibular joint. Over a period of time, those three symptoms will diminish. Now, what we've seen, and what I've seen after treating 3,000 cases, is that it's somewhat unpredictable how fast this process goes, but I tell all the patients who have these symptoms that expect those three symptoms, if they have them, to diminish much more slowly than the painful symptoms. And that is because it takes a while. How long? I don't know. What's a while? Is it 2 months? Is it 2 years? Is it 10 years for that inflammatory fluid to infiltrate through the petrotympanic fissure, the glossarian fissure, into the inner ear? I don't know. I don't know a way to test that. I don't know a way to study that. But over a period of time, it is certainly anatomically present that there is an entrance through that fissure into the inner ear. If it takes a while for that inflammatory fluid to infiltrate, it will take a while for that inflammatory fluid to calm down or decrease in effectiveness within the inner ear. And that's why it takes a long time for those three symptoms to diminish. Now, practically what I have seen for sure is that of those three, the subjective hearing problem usually diminishes the first, fastest, the vertigo next, and by far the slowest to diminish is tinnitus. Haven't done a study, although I've treated and successfully treated, upwards of 50 cases, successfully treating tinnitus, and eventually it diminishes, but may take many, many months. I tell patients tinnitus is almost always the last symptom to be relieved. It may take 4 months, 6 months, 8 months, or even longer. I've had several cases where it took a year with chronic use of unloading the joint with our device over a period of time, and actually just using it at night. It takes a while, and in some cases it goes faster. I have had cases where the patient says the tinnitus is decreased within a month. But there's no way to predict, and there's no way to put a metric on what to expect with this. But the anatomical feature within the glenoid fossa, the petrotympanic fissure, is obviously present and gives access to the glenoid fossa from the inner ear and access of the inflammatory fluids into the inner ear. So that is pretty much the gist of today's episode. I love some feedback from some of you who are watching this, your experience, your own personal experience with patients. Some of you actually have the experience of temporomandibular joint disorder yourself, the symptoms. We already know that if you're in a group of 10 females, the chances of having 4 or 5 of those females exhibiting temporomandibular joint symptoms are very high. It's really 45 to 50% of females exhibit temporomandibular joint symptoms of one kind or another. Some of them severe, debilitating, some of them not so severe and in the early stages of development. We also know that all of those symptoms develop over time. They get worse over time. And if you want to know more about that, you can refer back to some of the earlier episodes where I discuss, the symptoms of TMD and what you can expect when you start treating this problem. So practical aspects of this is profound, and that is that because of our work here in Middle Tennessee, we now have several ENT practices who actually have been enlightened on the fact that there's the patients that they see routinely, and they see tons of patients with those 3 symptoms: tinnitus, subjective hearing problems, and vertigo. They check the hearing. They go, we don't see any problem with your hearing because it's a subjective problem. They can't objectify it. Pretty much the ENTs in my career, when faced with chronic tinnitus, subjective hearing problems, and vertigo, just roll their eyes. They may call it, they may put a name on it, Meniere's, and treat it with drugs for a while. And when it doesn't go away, they roll their eyes and go, we just don't have a solution. At that point, maybe before that point where they even tried drugs, if the ENT will just do the examination of the temporomandibular joint, and if it hurts, that would signify inflammation in the joint, which would signify that it's very likely that inflammation in the temporomandibular joint is causing those three subjective symptoms. And we have enlightened several practices here in Middle Tennessee of the ENT doctors, and now are getting a routine number of referrals on a constant basis with patients with those symptoms. And interestingly, the patient presents with that one presenting symptom. It's like, this ringing in my ear is driving me nuts. And when we go through, as we always do, go through the whole litany with the patient, asking them, do you have any of the following symptoms? And the standard question is, I explain that, it's just a yes or no answer. And the question will be, do you have now, currently, recently, or ever meaning ever, had following symptom? And then you run them through the symptom list of headache, earache, jaw pain, neck pain, ringing in the ears, fullness in the ears, vertigo, shoulder pain, upper shoulder pain, arm, hand, finger tingling and numbness, and locking. And sure enough, patients will respond, well, yeah, I've had 2 or 3 of those, or you check them off mentally and put them in your chart. And you'll find that a great number, if not all of those patients, experience some or all of those other symptoms. They have positive examination finding when pressure is placed in the glenoid fossa. It hurts. And you made your diagnosis, in decreasing the inflammation by unloading the joint long enough will decrease those symptoms. Very simple, extremely simple. That's what I've never been able to get over. It's like the simplicity of this, and why so many of us, dentists, oral surgeons, ENTs, have been going around in circles and going around the block about this problem for so long, and not addressing the actual cause, which is inflammation. And the method to decrease the inflammation is unloading the joint long enough with a device that needs to be worn consistently. On what we found at the beginning, 24/7, usually for the first 2 months, and then nighttime after is the protocol. That is better known around here as the Urbanic device. If you would like to become a member of our network providers throughout the United States and Canada for our device, which is patented and FDA approved, you can contact us, either myself at Tony at tmjservices.net, or you can contact Naomi at tmjservices.net, and we will be happy to give you further information. You can also look at our website, which tells you the advantages and the method to become a network provider, and that is www.tmjservices.net. So I've really enjoyed this presentation, this episode, because it really went back to my background in gross anatomy and cell biology, which is one of the advantages that I had in sorting this out, and actually in developing a service that uses a device, which is nothing more than a tool, to unload the joint long enough to allow the inflammation to go down, which in this case will address those 3 middle symptoms, tinnitus, subjective hearing problems, and vertigo, very nicely. I look forward to our next episode, and I hope you have a very successful and productive week. Until the next time, I am Tony Urbanic. So long.